This is Namita Satenhotha for NEJM Catalyst. I am speaking today with Dr. George Diaz, part of the leadership team at the Providence St. Joseph Health System in Washington, who is helping to lead the response to the COVID-19 pandemic. He serves as Medical Director, Antimicrobial Stewardship, Infectious Disease Hospitalist, and Section Chief, Infectious Diseases at the Providence Regional Medical Center, Everett, which is part of the Providence St. Joseph Health System in Washington. He also serves as the System Provider Informaticist for the larger enterprise. Dr. Diaz and I will talk today about his experience with the COVID-19 pandemic. Our objective is to discuss care delivery, the very mission of NEJM Catalyst, during a unique and defining moment. Thank you so much for joining us today, Dr. Diaz.
Thank you for having me.
Share with us some background. Tell us a little bit about Providence St. Joseph as a system, how it's organized, and how it provides care for patients.
Providence St. Joseph Health has 51 hospitals, primarily on the West Coast, including Alaska, Washington, Montana, Oregon, California, New Mexico, and Texas. We have about 1,000 clinics. It has a central structure for clinical governance. Each of the specialties within the clinical arena has engaged providers that provide decision-making for the health system. Along those lines, we have a unified EMR. We are on the Epic platform, and infectious diseases content is one of the areas that I work in to build into our EMR. The hospital-wide practice infectious diseases is in Everett, Washington, just north of Seattle. We are a 600-bed hospital, the largest hospital in our county, one of the areas hardest hit with the current pandemic. We received the first patient in the U.S. with coronavirus in January, and as soon as the first patient arrived to our hospital, we activated our special pathogens unit and employed our dedicated volunteer staff of nurses and other staff that work with special pathogens. On arrival of the first patient, I began coordinating closely with our system leadership to begin a centralized response to what was likely going to be additional patients coming into our health system. Within 24 hours of the first patient arriving, we updated our electronic medical record to begin screening patients for possible coronavirus infection based on travel history. And by 5 p.m. the next day, all of our hospitals, including ERs, urgent care clinics, outpatient clinics, and any other ancillary clinics, were all screening patients, looking for possible additional patients that could be COVID positive based on their epidemiological risk.
Let me interrupt you just as we're at the very beginnings of this story from which we all have many lessons to learn. Let me clarify that I heard correctly that within 24 hours you had a template up in the EMR, and within, it sounds like 1 to 2 days, pretty much every part of the hospital was up and functioning in terms of being able to screen patients. How did you implement so quickly?
We have a leadership group that's led by Dr. Amy Compton-Phillips, who made a decision the night that we had the patient arrive that we need to be prepared for any patient presenting anywhere in our organization. We already had the framework within our EMR to rapidly upload different contagions for screening. We had done this for things like Ebola, MERS, SARS, etc. A tool that we designed ourselves within Epic to be able to allow us to turn on screening at the county level where outbreaks are often determined. In this particular case, because this appeared to be a threat that would not be limited to a single county, the senior leadership team within our health system provided guidance to our clinical leadership to implement this screening immediately. And so the build team began working essentially overnight to update the EMR to allow for screening across our entire enterprise.
And then what happened?
At that point, we began caring for the patient locally. One of the things that we noticed was that our team was prepared to receive a patient with, for example, Ebola, was limited to about 15 nurses. And so we knew that given what we saw in China, that the volume of patients coming into our health system potentially could grow exponentially. And so we began operational plans to increase the number of staff within our hospital to be able to have large numbers of nursing staff be adept at managing patients with potentially highly communicable diseases. This not only occurred at our hospital, but simultaneously occurred across our health system through centralized governance that provided the framework and an operational plan for readying staff for taking care of these patients system-wide. Within our hospital, we also began implementing plans for surge capacity. Thankfully for my hospital, one entire floor was built in a way that could accommodate the entire floor to be negative air pressure. That particular unit has 64 beds, and so we made plans for being able to cohort all of our patients, both COVID positives and COVID rule-outs, initially on that floor, so that we would have the nursing expertise localized to one part of the hospital, at least early on in the upcoming pandemic. The other things that we had to consider was how we were going to manage volume. What we saw happening in China was that health systems and hospitals were becoming overwhelmed by the sheer volume of patients. So we began developing algorithms within our health system to triage patients either for admission or for home. And since we knew, based on literature that was coming out of China, there was a substantial number of patients who would develop complications from COVID later in their illness, we felt that it was important to design a system that could detect changes in the patient's status if they happen to be discharged from the ED. We also knew that PPE would be potentially limited, and so we wanted to devise a way to minimize the use of PPE as much as possible while keeping patients safe. And so the solution that we came up with was to deploy our telehealth system in a way to be able to safely monitor both COVID-positive patients and ED discharged patients to home using our telehealth system. So we began building the tools within our EMR to support that workflow and began piloting that workflow at my particular hospital since we were one of the hospitals that were having the largest increase in number of patients coming in through our doors. And so we modified the EMR in a way that the patients could enter data themselves into MyChart, into their record, and created templates for the telehealth system to enter notes into the EMR so that anybody accessing the patient record would have access to the telehealth notes as well. We developed workflows for warm handoff between both ED discharges to home as well as inpatient to home discharges where the discharging nurse did a warm handoff to telehealth nursing. This program has allowed us to decompress and prevent admissions that are necessary. So far, we have in the range of about 200 patients within that system right now being actively monitored from home, and the number of patients returning to the hospital has been relatively small, on the order of less than 10. So the large majority of patients in our experience so far do well with home monitoring if they're stable, but a small fraction of these people do develop a change in their syndrome where they require readmission to the hospital. This also allows us to keep them at home and not use PPE in the hospital and open up hospital beds for additional sicker patients.
Sure. Let me interrupt to ask you a couple of follow-up questions in this part of the journey. The first is, where are we in time now? So the first patient came in January, and now you're describing algorithms and elegant workflows around warm handoffs and integrating telemedicine and telehealth. That's one question. The second is, in this time period, how are you managing testing? Because a lot of what you're just talking to me about is dependent on whether the patient is COVID positive or not. And then the third is also if you could talk a little bit about in these transitions between ED to home or inpatient to home, a little bit about the algorithms that you use to decide whether somebody was safe to go home or not. I think that is a big unknown. At least in my hospital, we're still working through how to be thoughtful about safety of sending people home.
So let me see if I can remember those three questions. I guess I'll answer the last one first.
Sure.
So the question about how you decide to send someone home from ED or inpatient. So we currently have clinical trials that give us entry criteria for at least what's defined as severe pneumonia by inclusion criteria to a clinical trial. And we've essentially used those as a way to determine if someone should be either actively monitored or admitted to the hospital. An example would be that the current trial looks at oxygen saturation, and if it's below 94%, for the most part, those folks will meet entry for a clinical trial, and if patients are close to requiring oxygen or have another reason for admission, the ED docs will then admit them to the hospital for admission. If patients then stabilize and oxygen levels improve in the hospital, then they can be discharged to telehealth from the inpatient setting. We're primarily using oxygenation status as the way that we determine if someone can safely go home from both ED and hospital. The second question that you asked had to do about the time frame between when we received our first patient in Everett and when we went live with this telehealth system. We admitted the first patient on January 20th. He was in our hospital for a period of about, I think it was maybe 8 or 9 days. And by roughly February 25th, we started seeing surge in volumes at our hospital. And by about March 3rd, we had began the pilot at my hospital to get people triaged either to home from ED or home from inpatient settings. So I would say it was roughly 6 weeks from the time the first patient walked in the door to the time that we were employing this alternative care model.
Congratulations.
I don't recall the first question.
Yeah. The first question this was the first question around putting all of this tremendous amount of progress into context of 6 weeks. The second question was many of these algorithms appropriately depend on whether a patient is COVID positive or negative. How did you handle the scarcity of testing kits during this time frame?
Right. So that's a great question. So one of the reasons we also thought that we needed to do telehealth monitoring was because early on when we started seeing surge in volumes, we did not have rapid access to testing, and it actually took as long as 4 or 5 days to get results. And so we were discharging in large numbers people under investigation rather than people that were COVID positive. And so once results came back from testing and they were outpatients, as long as they were clinically stable, and if they were COVID negative, they would be then discharged from telehealth. If they were COVID positive after discharge from ED or inpatient, they would continue to be monitored until near resolution of symptoms. The lack of testing was a big problem, but I think we mitigated it by being able to discharge many of these folks outside the hospital setting.
And then monitoring them via telehealth.
Exactly. So they would get hooked up with the telehealth nurse, and they would download Zoom at home, or if it was an elderly person that didn't have access to a computer, all the monitoring could be done by phone.
Given your experiences over the last few months, what will healthcare delivery look like in the future? How will it be different than what we knew pre-COVID?
I think what we're learning now is that in areas where we have populations that are growing, and perhaps we don't have the number of beds that are going to be built to support the increases in population, that we're going to need to rely on telehealth models to be able to provide care. Whether it be people that are actually local that can stay home. There certainly are large numbers of people that have difficulty leaving their homes and going to a clinic. Those patients could definitely benefit from telehealth services. Likewise, patients that live a little bit farther away from the hospital in rural areas where it's a burden to drive long distances to get care. I think these virtual visits will be a great way to expand care without expanding brick and mortar facilities.
What are some of the challenges that you've had with implementing and now sustaining and scaling this model as you're using telehealth to manage the pandemic? And what are some challenges you see, either same or different, in the future post-COVID?
I would say that the largest sort of management issues is really finding and being able to scale qualified staff to do sort of rapid scale increases in telehealth volumes. I think that if a health system has time and a plan, they can scale their staff appropriately. But scaling it rapidly, as we've done, really requires identification of the resources to create a program like this that can scale into a multi-state sort of scenario. The other area that's been difficult has been cross-state licensing. So currently, I think that we've had difficulty in being able to contract nurses in the state where they reside, where the patients live, if that particular state does not have cross-state agreements on credentialing.
To end on a positive note, share with us a success story from these last few weeks.
Well, the biggest success story, I would say, is that using our telehealth model, I think so far we've been successful in having patients be in the right place for the type of care they require. It's allowed us to not overrun our hospital with patients that could otherwise be at home but are COVID either positive or unknown. That's allowed us to not exceed our capacity at our hospital despite large increases in volumes that we've seen overall coming through our ED. We have had to cancel elective surgeries, as most of the hospitals in our area have also done. But our overall hospital census so far has been manageable. The other sort of success story, at least at our facility, has been that despite having large volumes of patients come in, with oftentimes, over 100 patients in the hospital who are either COVID positive or persons under investigation, we've not had any transmission of COVID to any of our healthcare workers. And I think that's in large part to cohorting these patients and maintaining nursing and provider expertise in PPE technique, which doesn't appear to have been broken, resulting in hospital transmission amongst caregivers.
Dr. Diaz, thank you so much for speaking with NEJM Catalyst today.
Thank you very much.